Yes, I'm sorry. So thank you very much, Prof. Ari, Prof. Morgan, and also dear doctors and the residents from Australia and also Indonesia. Thank you for coming for our first Australian-Indonesian joint lecture meeting. We will have this joint lecture actually every month. Hopefully all of you could join us as well. This is the first joint lecture between us. Now I will ask Prof. Ari to open our first meeting. Please, Prof. Ari.
Okay, thank you, Dr. Virna, Professor Bill Morgan, professor from Lions Eye Institute, and also the managing director for Lions Eye Institute Australia. And also thank you if attend this meeting, Dr. Andi Arus Victor, head of Department of Ophthalmology, Faculty of Medicine, Indonesia. And also there is a Professor Dr. Widya Artini Wiogo, one of our professor from Department of Ophthalmology, Faculty of Medicine. So as a Dean of Faculty of Medicine, I would like to extend my warmest welcome to all participants, and especially to this guest lecture from Professor Bill Morgan. I think it is such a great pleasure for us to have your presence with us virtually this afternoon here in Indonesia, in Jakarta. Yes, today's lecture will bring up the topic of glaucoma causative factors, contribution of scleral rigidity, blood flow, and CSF pressure. And I think Dr. Virna have prepared one presentation from the resident case with bilateral primary angle closure treated with early phacoemulsifications. And I think, yes, our lecture today is very eager to discuss the issue as a health provider, scholar, and more importantly, as a teacher. I hope that this lecture will enlighten participants and will lead to an engaging discussions. Also, this session will be moderated that one of our staff, Dr. Virna, mentioned. Through these lecture programs, I hope that Faculty of Medicine, Universitas Indonesia, and Lions Eye Institute could extend further collaborations in other fields such as research, collaborations, and also student exchange programs when the conditions is better. Lastly, I would also like to give my appreciation for committee members who have taken part of today's guest lectures. And I think we cannot wait to hear more of your insight, Professor Morgan, and ideas in person after this COVID-19 pandemic ends. Finally, I hope that everyone who gathers here can take benefit from today's discussion. And thank you for all of you who participation in this discussion.
Thank you very much, Prof. Ari, for your brief opening. And now we will go to the next presenter. Please, Dr. Iwan, to present your case presentation. Dr. Iwan is the resident in the Faculty of Medicine, University of Indonesia.
Thank you for the opportunity. First of all, I would like to thank to Dr. Virna, Prof. Morgan, the Glaucoma consultants, my teachers, my seniors and colleagues. In this occasion, I would like to present a case of a bilateral acute primary angle closure treated with early phacoemulsification. This case is supervised by Dr. Virna. My name is Ikhwanuliman Putra, an ophthalmology resident in Faculty of Medicine, Universitas Indonesia, Cipta Mangunkusumo Kirana Eye Hospital, Jakarta. This is a case of female 56 years old that came to the ER with sudden pain, blurry vision of both eyes, 3 days prior the with initially left eye and became painful along with blurry and reddish. She also experienced left-sided headache and vomit 1 time. The symptoms persisted for 2 days, and after that, the right eye also experienced the same thing. The patient instilled her eyes with tap water, but as we expect, there's no improvement. And a day later, patient presented to the ER. From the previous history, the patient admitted her right eye was already burst since 10 years pre-admission, but it's unspecific. The tunnel vision was denied. The patient used spectacles for reading, but no prior ocular history. She had hypertension, but did not take the medication regularly. No diabetes mellitus, allergy, or asthma. This is the ophthalmological examination findings in the ER. The position and the movement of the both eye were good. The presenting visual acuity was hand movement, good projection. In the left eye, the measured IOP was 60. We measured using the eye care tonometer. We found the ciliary injection along with conjunctival injection. Cornea was hazy with microcystic edema and iris pigment stuck in the endothelium. The anterior chamber was shallow with Van Herk 1, and cells and flare couldn't be evaluated. Pupil was mild dilated without retinal flex. We didn't observe any marked neovascularization or iris atrophy. The lens was hazy with glaucoma flecken, but in this picture, the glaucoma flecken was not seen clearly. The posterior part, the details couldn't be evaluated. The right eye actually experienced the same condition with the left eye with measured IOP 62 with ciliary injection, conjunctival injection, hazy cornea, shallow anterior chamber, with dilated pupil, and hazy lens. The ocular ultrasound was performed to make sure that the vitreous and the retina were in good condition. The patient was assessed with bilateral acute primary angle closure and senile immature cataract of both eyes. And then the patient was given the full anti-glaucoma medication, including timolol eye drops, atenolol eye drops, and for the anti-inflammatory agent, the patient was given prednisolone acetate eye drops. Also, the patient was given acetazolamide orally along with potassium aspartate. And for the hyperosmotic agent, the patient was given glycerin 50% orally. And then the patient was monitored for the IOP progression. If the IOP below 25, maybe the patient can be performed the phaco-IOL. This is the summary of the IOP and visual acuity progression after the medical treatment given to the patients. Actually, the patient responded quite well with the medication, and after 30 hours, the measured IOP on the right eye was 19 and 20 in the left eye. And then the patient proceeded with phaco-IOL of the left eye because this is considered the better seeing eye. This is the follow-up condition after the operation. The visual acuity still hand movement with projection, but the IOP lowered into 17. The patient continued the medical treatment. This is the photograph due to the hazy cornea. And then patients plan to phaco-IOL on the right eye 1 week apart. And to make the story short, of 1 month after the attack, which is 3 weeks after the operation on the right eye, the uncorrected visual acuity of the right eye 6/15, which is good, with measured IOP 16. We can see the clear cornea, deep anterior chamber, good IOL position, and cup-disc ratio 0.3, 0.4. And also with the left eye was also good with uncorrected visual acuity 6/12, measured IOP 13. Also with clear cornea, deep anterior chamber, and cup-disc ratio 0.3, 0.4. At this moment, the patient will not take any glaucoma medication. So the angle closure itself can be divided and classified according to the presence of the elevated IOP, formation of the peripheral anterior synechia, and the evidence of the optic nerve damage. The attack and the crisis itself can happen after the sudden obstruction of the angle that result in rapid increase of the IOP and give the characteristic signs on symptoms like our patient encountered. The attack itself can be self-limited or recurring and can lead to permanent visual loss if it's left untreated. Just the distribution of angle closure by the ethnicity. You can see that Inuit ethnicity has high preference angle closure. I see it's been between 0.3 to 1 of the angle closure from the demographic one and the pre-existing ocular condition. As we can see that the pre-existing ocular condition can be referred as the anatomical crowding that we'll explain in the next slide. The development of the acute primary angle closure itself can be because of the pupillary block. This is the most frequent etiology of the angle closure, or without pupillary block that may be encountered in some patients with plateau iris. It's been studied that several genetic predisposition can link to the development of the angle closure. And actually, the angle closure itself, it's anatomical because of the short axial length, shallow anterior chamber, lens disproportion, or maybe steep cornea. With the advancing age and with some environmental modifiers, patient can then progress to develop the angle closure glaucoma. Initially, the patient may be asymptomatic in the pre-clinical stage, and attack can occur with either mild one or the severe one, and patient progress to in the intermittent stage where the attack can be recurred. And if it's left untreated, the patient may develop the optic nerve damage, which in the chronic stage, and if the permanent visual loss occurred, the patient can be in the absolute stage. Because the angle closure itself is really anatomical because of the angle, the iris, the lens, and behind the lens, the flow resistant segments can be divided into 3 segments. The highest is the trabecular meshwork, and followed by the pupillary block and the ciliary block. For the examination of the patient with angle closure, we start with the good history taking, and for the physical examination, hyperopia can some patients. Also, it's important to examine the pupil for the size, shape, asymmetrical of damage, and the slit lamp examination is crucial. That maybe some patient will have the hyperemia, that also with the corneal haziness, iris abnormalities, lens change, including glaucoma flecken, the opacity of the anterior lens capsule, that present in the right picture here. And the gonioscope itself is important to distinguish between the true synechiae or appositional based on the indentation finding. For the anterior segment imaging can also be done with anterior segment OCT or UBM. And for the acute attack that develop in our patient has symptom, periorbital or ocular pain with diminished vision, and also with the findings characteristic for the acute attack, like ciliary flush, idiom cornea, shallow anterior chamber, my dilated pupil, and so on. Also, we can observe if there is findings that suggestive for the previous episode of the acute glaucoma, like the synechiae, glaucoma flecken, or iris atrophy. There are several modalities that can be used to manage the drugs can IOP of the pulse and protect the structure of the angle. Also, the laser therapy, iridotomy itself can be done using laser or surgical, but laser is the preferred one. And also, peripheral iridoplasty can also be done. The next is surgical intervention. This is some of the drugs that may be used in the clinical settings, from the beta-adrenergic antagonist that patient give timolol, prostaglandin analog that also we use in our patient, and also oral carbonic anhydrase that we give to the patient, and hyperosmotic agent, we give the glycerin. And in our center, there's no acetazolamide IV, and mannitol is reserved for patients that cannot tolerate the oral agent. As we can see that in the flow diagram on the right, after giving the anti-glaucoma medication, then confirming the crisis, the patient can have a laser iridotomy from the guideline from 2015 from American Academy of Ophthalmology. And if this is unsuccessful, a patient may take the LTI. And if patient have the patent iridotomy and the IOP is still uncontrolled, maybe some surgical intervention is needed for the patient. Interestingly, in the several years, the role of lens extraction has been emphasized, but this is technically difficult and challenging, and maybe poses some risk of intraoperative complication because maybe patient uncooperative due to the pain, shallow anterior chamber, or maybe the hazy cornea. But from the literature, if the patient with lens extraction had lower glaucoma medication compared to the LTI. But currently, there is no golden period to perform the lens extraction, but it's proposed that the earlier it be done, the lower the chance to further pus formation. And the lens extraction itself can be combined with trabeculectomy, like phacotrabeculectomy. But there's still a risk of ciliary block, because actually if the patient can be seen through the gonial lens, that we can see that the iris process here from the gonial lens, and because of the lens touch the ciliary process, and maybe this individual poses risk to develop ciliary block after the intervention, even after the patent iridotomy or after the lens extraction, due to the hydraulic pressure that built up in the anterior vitreous interface. This is because of the intervention that we gave may resolve the trabecular meshwork and pupillary block resistance, but the ciliary block may be reserved for some individuals. This is some of the studies that compare phaco with peripheral iridotomy. In general, early investigation resulted in the lower IOP, and also by patients. From that the postoperative IOP is decreased compared to the LPI, and no surgical additional surgery required. From the Hussein et al. Of phaco and LPI, actually the phaco slightly higher, but the needs of the further surgical intervention is lower compared to the LPI. And the other three, Jacobi et al. Compared phaco with surgical peripheral endectomy, resulted in the lower IOP in the phaco, and in these two study compared phaco compared to the LTI and then followed by phaco, that result in quite very well in a patient with phaco compared to the LPI only. This is the study that published last year. It's quite interesting. Even this is a retrospective study. They compared three groups of patients. The first is group a patient with primary phaco, and group B is LPI followed by phaco, and group C was LPI only. So you can see that even if we can see that in the group A, the preoperative IOP is quite slightly higher in group A compared to the other group, but you can see after the intervention, actually after all three interventions, the IOP can be controlled. But if we divide the patients based on the anti-glaucoma medication that required to control the IOP, for the complete success and the qualified success, if still there is a medication that required, you can see that the complete success of group A was highest compared to the others. So early phaco may be beneficial for this kind of patient with the primary angle closure. In summary, the acute primary angle closure and crisis is an optometrical emergency that needs timely intervention. The lateral attack is not impossible and should be carefully managed. And there is growing tendency in recent years to perform early phaco emulsification and IO implantation. But long-term follow-up still required to ensure that patients have the best visual condition. Thank you.
Thank you very much, Dr. Ivan, for a very nice presentation. Is there any comment or is there any question? Or Prof. Morgan maybe want to comment about this?
Oh, yeah. Look, Dr. Patira, that was a lovely presentation. I've just got two comments. One is that these cases, you get very severe cases in Indonesia where it's impossible to do gonioscopy. And I think for our Australian colleagues, it's hard to imagine that, but it's definitely true. And often these patients have had high pressures for some time, so their corneas take a long time to recover. Fortunately, we don't see that severity. And usually we can do gonioscopy, particularly after the acute pressure rise has subsided with medical treatment. So there's a sort of slight difference in the severity. And I guess the one time I've only seen bilateral acute angle closure once or twice, and actually both those occasions were due to drugs, actually. And I've forgotten the name of the drug. It's one of those ones that gets used sometimes for weight reduction. So I would just say it's really important to take a drug history of the patient. So some of those drugs that can cause supraciliary effusions, even the sulfonamides and topiramate drug I'm thinking of actually, which is classical. I don't think it's used as much as it was used some years ago, but it's worth taking a drug history as well. But I thought your presentation was very clear and excellent, and also the literature summary at the end was really excellent, particularly pointing out the relative benefits of lens extraction. And I don't think we've landed yet at a sort of well-defined position for when to remove the lens versus when to do laser iridotomy. But thank you very much.
Thank you, Prof. Morgan.
Thank you, Prof. Morgan. So we do hope that maybe the doctors here or the residents here also could learn about the acute angle closure glaucoma. And we know that it is very hard cases, and hopefully we could manage it well, because if we don't do the proper management, it will be a blindness for the patient actually. Like we ever see also in our hospitals, some patients some patients came with late condition because of the condition. So if we could do the intervention early and then manage it properly, hopefully the patient could benefit with the management. I think you agree with that as well, Prof. Morgan.
I do, definitely. Thanks, Virna. Yeah.
Thank you. Okay, now we will proceed with your presentation, I think, Prof. Morgan.
Thank you. I'll try and share screen and not get muddled up with the computer. Oh, here.
Thank you, Prof.
I think, can everyone see that? I hope so. I changed the title. I shortened it a little bit, actually. And I really wanted to discuss the, if you like, the causes or the cause and appearance of glaucoma, because essentially the treatment that we do is all about treating the cause and understanding what causes glaucoma and what it looks like helps us diagnose the disease earlier and also even to detect progression. So I'll start on this, and I just put this slide up of a beautiful Indonesia. I'm able to get to Indonesia for a time now. Oh, here we go. So as you know, glaucoma affects the optic nerve head or the optic disc, and it's defined as having a typical appearance. And I'm going to talk to you about the fact that the appearance, which is cupping and excavation, effectively that's a distortion of the laminar cribrosa or the connective tissue. Between the eye and the cerebrospinal fluid or the CSF space. And it leads to damage of the nerve fibers, but it's not just damage of nerve fibers that is glaucoma, it's this characteristic distortion and change in shape that tells you that it's a disease of force in effect. So this is just a schematic diagram showing you going from a healthy nerve on the top left across to a deeply cupped excavated optic nerve on the right. And you can appreciate that there's been a force applied to this nerve over time, leading to the damage. So this is a collection of histological images showing the laminar cribrosa, the tissue in front of the lamina or the prelaminar tissue and the optic nerve. And you'll see going from left, which is normal, to moderate glaucoma to severe glaucoma, you'll see accompanying OCT scan. So these days we're lucky to have OCT scanning through the nerve showing similar features. And also you'll notice that the laminar cribrosa in L between the dotted lines has been compressed very much. And that's a big change in glaucoma. It's also worth noting that the principal damage to the nerve fibers occurs in the posterior or the back part of the laminar cribrosa. And this was well demonstrated by a very famous pathologist in Dr. Vrabec in 1976. And here you can see this is a patient who's died with glaucoma, and you can see axons that have been interrupted in the posterior laminar cribrosa trying to re-sprout. And that's what happens to the nerve fibers in patients, is that they get, if you like, chopped in half or interrupted by a force acting across the lamina. And then they try and survive and re-sprout, but inevitably they die back and end up killing the ganglion cell bodies in the retina. Oh no, I don't think that, oh, this might work. Now, this is just a diagram I drew some years ago showing of an axon and illustrating that in an axon, such as the ganglion cell axon, you need to move material up and down from the nerve cell, so in the retina, along the optic nerve back to the brain, to the thalamus or the lateral geniculate body. and you've got to move mitochondria and other material back up and down the line, so to speak, like it's a series of little railway tracks. And that glaucoma basically interrupts this. And it's well known in animal experiments that glaucoma gradually affects and destroys the ability of the ganglion cells to move material. And that's the principal reason why they die off. And the interruption occurs at the lamina cribrosa. Now, why is the lamina cribrosa so vulnerable? This is some modelling experiments that have been done by a Canadian bioengineer looking at where stress, which is the force per unit area, and also strain, which is the distortion, occurs in a normal optic nerve, and then when the pressure is elevated to a high level. And you'll see where the yellow and red is, but that's where areas of high stress and strain occur. So you're getting compression forces acting in that particular region. And it explains why you get excavation. It's almost as if the forces are moving the tissue towards the subarachnoid space. And that leads to this excavation, this sort of cavity effect underneath the optic nerve. So that leads one to suspect that it's the relationship between intraocular pressure and CSF pressure that matters. And these are results from a series of experiments that I did myself 20 years ago, measuring the pressure gradient across the lamina cribrosa at different intraocular pressures and different CSF pressures. So the red dots and black dots are when the CSF pressure was 0, which is normal. And you can see when the pressure was elevated from 15 to 26, the gradient was much increased. If the CSF pressure went up, then the gradient was decreased. You can actually estimate that. These experiments were done in dogs. We measured the gradient, and it happened to be, on average, about 25 millimeters of mercury per millimeter of tissue. Now, that was when the intraocular pressure was 16, and if you increase the intraocular pressure to 28, in fact 25, then the gradient would double. So the pressure gradient would increase to 45 millimeters of mercury when the intraocular pressure was just 25. That happens to be at the point at which axonal transport and effects on transport start to really occur. We did some modelling work in human eyes, and we found that the gradient was much the same. We couldn't measure this in human eyes, but we looked at the differences in connective tissue and modelled the gradient, found it was much the same in human eyes. And one other factor we then considered, I'll go back, was that the lamina cribrosa thickness itself modifies the gradient. So imagine that the pressure has to be distributed across the tissue, and that the normal lamina is about 400 to 500 microns in thickness. So in this situation, in the left-hand slide, the gradient in the human would be about 20 millimeters of mercury. But if you have severe glaucoma on the right-hand side, when the lamina cribrosa is thin to less than half the normal thickness, then the gradient will more than double to about 46 millimeters of mercury. And that's even with this intraocular pressure at 15. So it might have gone up previously, but it's been brought down to 15, but the gradient is still high. The situation for the lamina cribrosa is worse in myopes. So the bottom table shows you the typical lamina thickness in a high myope's eye. So in a normal myope, it's only about 200 microns compared to 450 microns in a normal eye without glaucoma. So the myope is starting off in a worse position. So their gradient's already high, even if their intraocular pressure is normal. So What's the real deal with pressure? Well, we know that as intraocular pressure rises, the risk of getting glaucoma over the subsequent 4 years increases like an exponential function. It goes up like this. So that if you have a pressure of more than 30, you're at least 40 times more likely to get glaucoma than if you have a pressure less than 16. So the thing is to remember, it's not a linear function, it's actually an exponential function. So the risk gets much, much worse at higher pressures. The normal distribution of intraocular pressure is like this, and this is a log scale on the left, on the y-axis, and you'll see that the pressure in glaucoma patients tends to be higher, but isn't always, and so that's why we have this subset of patients we call normal tension glaucoma, but it tends to be higher in glaucoma patients. This is another reason why we don't use intraocular pressure in the diagnostic criterion. So we say it's a disease of typical nerve damage and visual field loss, but we don't include the term pressure because it's not always that you have a pressure that's out of the normal range. What about CSF pressure? Well, we know that CSF pressure tends to be lower in glaucoma patients at about 9 millimeters of mercury when you're lying down, compared to 13 in the normal patient when they're lying down. This is on average. So if you have a lower CSF pressure, then theoretically you'll have a somewhat elevated gradient in pressure, pressure gradient across the lamina. Let's put all of this in pictures. It's hard to imagine what these numbers really mean, but let's suppose you have a patient who's, say, 20 and they're healthy, and they're the black dots. So they've got a laminar cribrosa, which is about 400 and something microns thick. So on the x-axis, it's from 200 to 650 microns depth of tissue. You can see the gradient is relatively gentle. It's about 20 millimeters of mercury per millimeter of tissue. Let's suppose that the pressure gradually rises over, say, 10 or 20 years to be now 25. It goes up from 15 to 25, and the CSF pressure stays the same at 0. Now, that pressure gradient will actually double in that time to be 40 millimeters of mercury per millimeter, and the patient's optic nerve ganglion cell axons start to have problems. And over time, the laminar cribrosa starts to compress and get thinner, and the gradient starts to be amplified as well. So if it thins to 200 microns, the gradient doubles to 80 millimeters of mercury. And fairly rapidly, the patient starts to lose vision because the disease really starts to accelerate. Now, you might treat them, diagnose them and treat them with drops or surgery, lower the pressure back down to 15 and think that you've done a wonderful job, and you have done a wonderful job. However, the pressure gradient is not necessarily brought back to normal. You might reduce it from, say, 80 down to 40 millimeters of mercury per millimeter of tissue. Now, I've exaggerated these figures a little bit just to emphasize the point. It may not be as dramatic as this, but I think you'll see the point that I'm getting to is that even if you do normalize the pressure, you may not actually recreate the normal physiology, and the gradient still may be elevated. And that probably explains why patients still get worse even when we do normalize the pressure. So let's give a few examples of glaucoma. We've talked about the histology and the physiology. And let's remember that in glaucoma, you really need to see some evidence of laminar cribrosa distortion and compression. So that means excavation. You also want to see some signs of nerve fibre layer interruption and loss, so usually field loss. And sometimes you'll see a disc rim hemorrhage or a vein occlusion. And that leads to glaucoma, or that is glaucoma. Now, I did say I'd talk a little bit about blood vessels. I'm not going to talk much. The major change in the blood vessels in glaucoma is actually in the veins. Here's some histology of the veins, and in the laminar region, the vein endothelium becomes much more like that of an artery because of the high pressure gradient. And this probably, we don't know for certain, leads to other problems in the veins, possibly making them more susceptible to an occlusion. And it may also have effects upstream and lead to disc hemorrhages. But we actually don't know what causes the disc hemorrhages, except to know that it's definitely an effect upon the blood vessels induced by glaucoma. So glaucoma, it's a disease of classic optic nerve appearance and visual field loss. So on the left side, you have a normal eye, normal visual field. They start to get glaucoma with damage to the nerve and excavation inferiorly with a disc hemorrhage, and that leads to a superior arcuate field defect. And the whole process gets worse over time, leading to a very constricted field. So some examples, and here I'm going to show you a classic one, then some unusual ones. And I just wanted you to bear in mind the fact that you ought to see some excavation if you're going to make the diagnosis of glaucoma. Now, here we have a standard OCT scan. Because of the excavation that goes underneath some of the sclera and overlying tissue, you usually have a kind of shadow artifact here. But just bear in mind that this is almost exactly going to be the region where the major forces are acting, and that within less than 0.5 millimetre of the vitreous cavity is going to be the subarachnoid, so the CSF space. So the compression in that zone is going to be highest, exacerbating the excavation over time. So here's that same scan. You can get an impression that the excavation was here. The patient has got quite markedly thinned optic nerve fibre layer in a circular pattern, and you can actually see the optic nerve excavation. This is a patient with high myopia, and this changes all of the force distribution. So in a high myope, for some reason, which we don't really understand, it's very common for the subarachnoid space, so the CSF space, to be very much expanded around the optic nerve. And that leads to thinning of this overlying sclera, and also the forces now can act directly through that tissue towards the subarachnoid space or the CSF space. And that leads to posterior staphylomas. What it also does is that it means that the difference in connective tissue strength between the lamina, which is usually weak, and the surrounding sclera is not so great. So the forces, instead of finding the easiest way to distort things through the lamina, now are kind of more evenly distributed, and the degree of excavation across the lamina is a little bit less. So it can make diagnosing glaucoma more difficult. So whenever you see high myopes, particularly those with significant posterior staphyloma, it's almost certain that their CSF space is expanded in that zone where the posterior staphyloma is, and it's going to distort the appearance of any excavation in the optic disc. So be very careful about saying that someone does not have glaucoma. It's actually quite difficult sometimes. OCT scanning through the optic disc does help, and I'll show you some examples. This is an example of a high myope with small optic discs. Now, when I show this to most people, most of our registrars, they will say that the disc margin is here. Well, that's not actually true. This is all peripapillary atrophy. The disc is only this zone here. And correspondingly, this is not the optic disc. This is mainly peripapillary atrophy. This zone here is the optic disc. And if you look really carefully, there's a little bit of a pale zone contrasted with the slightly more red neuroretinal rim. This pale zone is a little excavated and it corresponds to possible glaucoma. And you'll see here, this is that left visual field, which shows quite marked field constriction, really confirming the diagnosis. So this is another patient who's a myope as well. And first, look at the OCT scan. There is some excavation, but it's not as pronounced as you would normally get because of that issue with the biomechanics of a highly myopic eye. You can actually see the excavation on the optic disc. You can also see a disc rim hemorrhage. So disc rim hemorrhage is very helpful because it raises the likelihood of glaucoma enormously in some of these patients, particularly when the disc is not so obvious. Now this one is a tricky one. This one was referred to me about a year ago, and when you look at the visual field, you'll see a typical inferior nasal step defect. But when you look at the optic disc, you're really looking for a change in the supratemporal region, aren't you? But there's nothing there, and it even looks relatively pink. And the vertical cup to disc ratio is about 0.2, 0.3. It's normal. So what is going on? I mean, that's a tricky one. So let's have a look at the OCT scan. Now, the OCT scan is quite abnormal. Perhaps first look at the ring scan around the optic nerve, and you'll see this zone of sort of multi-layered schisis or schisis splitting a zone of the retina. And here, if you look at the scans through the optic nerve, you'll see this schisis extending into the prelaminar tissue of the optic nerve head itself. So now, if you look carefully at the sclera becoming laminar cribrosa, it's a little sharper, the edge here, than the other side. So maybe there's actually a little bit of laminar scleral distortion, and that what we're seeing is, for some reason, we're getting a schisis, which is masking the actual contour of the optic disc. Now that's a hypothesis, if you like. What was helpful is when we looked at the other eye didn't have any schisis, and if you look carefully here, you'll see some inferior notching. You'll also see a disc rim hemorrhage, and you'll see the visual field with the superior nasal step defect matching that inferior notching. So this is obviously a classic case of glaucoma on the other side. So it's a fair bet that glaucoma is also operating on the left side, and that its appearance was being masked by the schisis changes in the prelaminar tissue. So there are a few traps when I say and tell you, if you like, to always look for excavation and a change in shape. I have to say it's been very helpful to have OCT scanning, where you can look at if you like, the histology through the nerve. This is just two cases quickly that I saw last week at Royal Perth Hospital. This is a classic case of glaucoma. You'll see the very marked excavation, very unfortunate young man, only 21-year-old, with congenital glaucoma. This is his only eye, and you can see he's lost a lot of his nerve fibre layer. But this is a classic case of glaucoma, and you've got this classic sort of piston-like effect where you can see that the laminar cribrosa central optic disc has been rammed backwards by the chronic force from the pressure gradient. Okay, this is the very next patient who walked in, labelled as glaucoma. Now this is a tricky one. Certainly if you look at the nerve fibre layer thickness on the right-hand side, that's the solid line, it's well and truly reduced inferiorly and superiorly. If you look at the nerve contour, it's pretty much normal. There's no excavation. But look at these things here, these cystic spaces. The patient's got optic disc drusen. So there are other causes for nerve fibre layer loss, like optic disc drusen, like optic neuropathies in general. So not everything that has a field defect and nerve fibre layer thinning is glaucoma, so be careful. Now, optic disc drusen are a special case. This is the other eye, had possibly slight changes in the superior field, but I would be dubious about those. But when you looked at the nerve fibre layer, there was some thinning inferiorly, which you could see clinically. I don't have a photograph here. And you can actually see a slight amount of excavation here on the OCT scan. So this patient, she also had a slightly elevated intraocular pressure of 23 bilaterally. This patient almost certainly has got left-sided, very early, almost pre-perimetric glaucoma. On the right-hand side has optic disc drusen as the standout feature, but could well have an element of glaucoma as well. And it's really impossible to distinguish between the two in this scenario. So my own practice is to treat for glaucoma anyway. You can't treat the drusen, but you can treat the glaucoma. So she's now on treatment in both eyes for the glaucoma. But nevertheless, be careful. Patients who have a field defect and a nerve fibre layer defect don't always have glaucoma. They have to have a classic appearance to their optic disc. And you should always be suspicious if the whole setting doesn't match. So I'm going to finish in a little bit. Just want to talk a little bit about the risk of ongoing damage to the nerve. So now that you've diagnosed glaucoma, how do you treat it? Well, the only treatment at the moment is to lower pressure. And this famous study, Early Manifest Glaucoma Treatment Trial, demonstrated that for every millimetre of mercury you reduce the pressure, you get an 11% reduction in risk. Or conversely, for every millimetre mercury rise in pressure, there's an increased risk of 11%. And again, that's an exponential function. So it goes up like that curve I showed before. There are some other risk factors, so frequent disc rim hemorrhages, certain subtypes of open-angle glaucoma like pseudoexfoliation, and also the severity of glaucoma. So if you have a mean deviation of more than -4 decibels, then you're much more likely to progress. And it's probably because of that effect upon the laminar. So by the time you get to that stage, you've got some laminar thinning and compression already. So already the disease is starting to get a grip. Now, let's think about what 11% compounded or exponential function looks like. So I plotted these curves. You can do this in Excel easily. And it's going to be between the yellow and the green lines. So you can see how the effect looks very much like the curve that you saw earlier with the risk of getting disease depending upon intraocular pressures. So what our treatment does is basically when you lower intraocular pressure, let's suppose our patient is on the green line and their diagnosed pressure just above 30, the relative risk of getting worse is in excess of 12 times. You want to shift that curve down the green line to a relative risk of, say, under 2. That would be nice. So in order to do that, you've got to reduce the intraocular pressure down to about 15. So that's really all that you're doing is shifting the patient along this curve to the left, to a lower relative risk zone. That's what you are doing when you lower the pressure. Now, if the disease gets worse, then the shape of that curve gets worse. So see this curly arrow. Over time, with worsening disease, worsening changes in the laminar cribrosa and other factors we probably don't understand, I call them fragility factors, the curve will tend to shift its shape and go towards the blue and the orange. And that means that the relative risk increases at any given pressure setting. So it becomes even more important to keep that pressure right down at a very low level. And that, in essence, is the principle for managing glaucoma. I mean, I think if you think about that slide and that graph, it almost encapsulates everything that you need to know about managing glaucoma. So just to summarize, in glaucoma, one should always look for and hopefully see signs of mechanical damage, such as excavation. And if you don't see it, you should look for why you're not seeing it. And OCT scanning is very helpful there. It is useful to imagine what's actually happening in that zone, and especially in relation to the subarachnoid space or the CSF space, particularly in high myopes. Now, laminar cribrosa properties influence various factors, such as the pressure gradient, probably the shape of that relative risk curve that I just showed you, and it worsens with disease. So as the disease gets worse, the shape of that curve, the vulnerability and fragility gets worse. And at the moment, we can only shift the patient along their curve to the left by lowering intraocular pressure. So thank you. I'm going to stop here. I'll stop sharing because I'd rather see you all, not the slides. And are there any questions?
Thank you very much, Chef Morgan, for the very nice talk. I've just seen one question actually from Dr. Hanifa. The question is about the patient with considering the shallow anterior chamber and also hazy cornea in preoperative examination. Is there any choice for cataract extraction other than phacoemulsification for this case? And what we should consider intraoperatively when doing phacoemulsification in the case of acute primary angle closure?
Yeah, that's a very good question, actually. Yeah, well, you can do, say, an extracapsular cataract extraction, but the risks are much, much higher, unfortunately. It's phacoemulsification, and I think that's a major reason why it's only recently, with widespread use of phacoemulsification, that people are doing this. The risk of a choroidal expulsive hemorrhage in a patient with previous high intraocular pressure, and also likelihood of ciliary block with an extracapsular cataract extraction is, I think, relatively high. So you'd want to try and avoid that if possible. Or if you're going to do it, then make sure that you'd control the pressure for at least a few days or a week or more to allow the eye to settle right down. And also that will improve the corneal clarity, make the surgery easier. Obviously, phaco is easier if the cornea is clear to do the capsular excess in particular. But also extracapsular cataract extraction is easier as well for doing the capsular beer can capsular excess, or whichever one you tend to use. Yeah, so I think phaco makes it much safer to do, basically. But it's not always easy. The shallow anterior chamber can be a definite problem. And certainly the very viscous viscoelastics help here. You can get ciliary block intraoperatively. I've only had that once, but that's very frightening when it does occur. And you may actually have to do a vitrectomy or a tap of the vitreous in that setting. It's another reason to try and avoid doing these cases hot. So if possible, let them cool down with medical therapy for at least a few days, if you can, before you do the surgery. And as the first speaker said, try and look for signs of ciliary block if you can do a gonioscopy. It will at least warn you that the possibility of problems is there when you do the surgery. So you go in sort of almost thinking the worst. Usually things don't turn out that bad. Thanks, Virna.
Thank you, Professor Morgan. Yes, sometimes it is difficult maybe for the shallow anterior chamber and also a hazy cornea, right, Prof? So we try to clear the cornea first, and if it is clear, then it is easier for us to do the phacoemulsification. Because if we do the like opening like ECCE, it will be I mean the risk for choroidal detachment, right, Prof? Suprachoroidal hemorrhage, I mean. So if it is possible, we should do it with phaco, but we try to clear the cornea first, like that, Professor Morgan?
Yeah, exactly. And you know what, I think you people in Indonesia are more experienced at this than I am, or we are. You get the worst angle closure cases and the worst corneas, actually. So I should be listening to your advice, actually.
Yes, Prof. Actually, in our country now, especially in my hospital as well, in this pandemic era, I've seen quite a lot patient with acute angle closer glaucoma, actually. Every week, I have at least 1 or 2 patients with acute angle closer glaucoma or acute angle closer. So I don't know, maybe it related with the stress for the condition, maybe. But we have a lot of cases nowadays. So sometimes I have to perform phacoemulsification on those cases because we have the very, I mean, the lens is also swollen, and then the acute attack is very prominent on those cases. Thank you, Professor Morgan. Dr. Iwan, do you want to comment from what you read?
Thank you, Prof. Morgan. Dr. Virna is maybe Dr. Virna has a lot of experience with this kind of patient. From I've read, maybe there's also a reported stated small incision cataract surgery or 6 can be performed, but after the IOP getting lowered and the cornea become clear. But in that settings, the number of the patients that we reported is below 20, if I'm not mistaken. So maybe in a broader condition, it's safer to do phaco.
Okay, thank you, Dr. Iwan. And now the second question, Prof. Morgan, this from Dr. Dita.
Yes, oh, thank you. I've got that. So yes, so Dr. Dita is saying that some drugs like Diamox lower intraocular pressure and also lower intracranial pressure. That's a good question. Now, at the moment, we can't measure intracranial pressure non-invasively, so we don't actually really know how much relative lowering, as in the difference between IOP and CSF pressure lowering there is, because we can't take those measurements. I've actually oversimplified the relationship between intracranial pressure and the gradient. We actually, in your body, you have orbital tissue around the optic nerve as well, and the orbital tissue has its own pressure, which acts as what we call a buffer. So intracranial pressure lowering ceases to have an effect below a certain point because of the orbital pressure. So even if the intracranial pressure drops very low, as in below atmospheric pressure, which it probably would do, it may not have that much effect in terms of exacerbating the pressure gradient. And so that's probably why Diamox is quite a good drug. But the truth is we simply can't take those measurements in large numbers of people, so we don't know for sure. The corollary to do with orbital pressure is that some drugs lower orbital pressure. The most famous one is Lumigan or bimatoprost with orbital atrophy over time. So we actually don't really know whether that's a good thing or a bad thing. I try to avoid using Lumigan in patients unless I really have to, but we don't have evidence for that yet.
Thank you, Prof. Morgan. So we at now we still consider only IOP, right, Prof? Because we don't have measurement for the intracranial pressure.
That's correct, yes.
Okay.
But I think it pays to think about it, but we can't do anything about it. Although if you're a man, you can wear a tight tie around your neck and force the venous pressure to go up. Maybe that would help. But of course, that's impractical.
Thank you, Professor Morgan. And now there is also a question from Dr. Krishna, Prof.
Yes.
With high myopia patient.
Yes, so that's a good question. So I'll just reread Dr. Krishna's question. It is still very hard for me to diagnose glaucoma in high myopia, especially when the intraocular pressure is between 15 and 21. Which one is better, wait and see for signs of progression or give early treatment? Now, I don't have a clear answer on this. I think you've really got to use your judgment. Some people would call that sort of gestalt. It's like all of the information you think about goes into your brain, and then you think, what's the most likely scenario? So what I suggest is look very hard for signs of excavation. Often it's just like a little saucery dip. And if you see that in the optic nerve, if you see that in a high myope, then it's almost certainly glaucoma. But you have to really look hard at that optic disc. And OCT scanning does help. You saw the scans through the optic nerve. Now, if you get nerve fibre layer changes, and the problem with high myopes especially is that there are all sorts of other changes going on in that peripapillary zone, and it's very common to get schisis, for example, other sorts of changes. So often the nerve fibre layer scans are unreliable, but sometimes you get good scans, and so that can help, but not always. And then finally, it's the visual field. But again, if you've got zones of peripapillary atrophy extending outwards, you have to take that into account when assessing the visual fields, potentially tilting, although in practice I don't pay too much attention to tilting. I'm more interested in the peripapillary atrophy. So all of the, and then finally the intraocular pressure. And it can be helpful to know what the intraocular pressure was, say 5 or 10 years ago, if anyone has a record of that. If it's gone up, it would suggest that the pressure has increased significantly and that the gradient has increased, and that probably you ought to treat. Whereas if the pressure was, say, 15 when they were 20 years old and 15 when they're 40, and there's not really many signs, then probably just watch. I don't think I've given you a very good answer, but it's really just trying to balance all the signs that you can detect and then formulate an opinion. And the other thing to do is to talk with the patient, let them know what your concerns are. Some patients may actually say to you, look, I'm worried, I want to be treated. Most people will take your advice, I find, once I've explained to the patient. But yeah.
So, Professor Morgan, how long usually observe a patient with high myop? Is it like a usual 6 months, every 6 months you do the OCT examination and also the perimetry, or it is longer, or it is even shorter time for you?
If the intraocular pressure is normal and you...
Yes, if intraocular pressure is normal and you think it is suspicious for the patient, but you can't, you don't want to start the treatment?
Yeah, normally I'd see them once a year.
Oh, once a year.
And increasingly, we have a lot of optometrists in Australia. So sometimes if they're I might say to them, go and get your pressure checked in 6 months, but come back and see me in a year. But often I just see them every year, actually.
Because we don't have optometrists in here, Prof. So
yeah.
just...
You have to see them yourself. Yeah, that's the problem. Probably once a year, I think. If there's no other suspicious signs or risk factors, yeah.
But if there is a risk factors, it will be shorter time. Maybe like the family or the family history or something like that?
Yes, I think so. Could be shorter. And then if you follow them, say, every 6 months for 2 years, but nothing changes, then you probably stretch it out to once a year.
Okay. Yeah. So Dr. Krishna, hope it will answer your question. And now the next one is from Dr. Marcia, Prof. From Dr. Marcia. The question...
Yes, sorry.
Yes. It is actually iridoplasty, Prof. Alpi
Oh,
is
yeah. Right.
for iridoplasty.
That's a very good question, actually. So if the cornea is relatively clear, laser iridoplasty, peripheral laser iridoplasty is very helpful and will help open the angle and lower the pressure and get an even more clear cornea, which can allow you to do a laser iridotomy, for example, or get better control. So yes, we didn't mention this, but peripheral laser iridoplasty is very helpful, and you can do it even when the cornea is a little bit cloudy, whereas you can't really do a laser iridotomy if the cornea is cloudy. So it is very helpful.
Thank you, Professor Morgan. I think I have seen also Dr. Tria doing that in patient with acute glaucoma with a hazy cornea. Yes, Prof. And now the next question from Dr. Desi Mandala, Prof. About a young age patient. Is there any different effect to the optic nerve head damage?
Oh, I see.
Yes, if we can lowering the IOP compared to the older patient, and what factors could influence mannitol cannot give a satisfactory effect lowering the intraocular pressure?
I'm sorry, I'm just rereading that question. Thank you. Is there a difference? So basically, I think you're asking if the optic nerve looks in glaucoma looks different if the patient's young or old. And the answer is no. It still looks excavated. It doesn't really look any different. So a congenital glaucoma patient with severe long-term glaucoma will end up with a very cupped optic disc, the same as an old patient with severe end-stage glaucoma. So not really any different. The one difference is that there's a bit more what I would call plasticity in a young person's optic disc. So if you do operate on them, then you'll get some reversing of the cupping and excavation. So it can start to look almost normal in patients who, they might go from a vertical cup to disc ratio of 0.7 back to 0.4, for example, or 0.3. I've seen that sometimes. Whereas an old patient, you don't tend to get much reversal when you lower the pressure. That's probably the only difference I've really noticed. And then the second part of your question was to do with mannitol. And sorry, I didn't really understand the question. What factors can influence mannitol effect and not giving a satisfactory effect? I think it's not the mannitol per se, but I think you mean, usually we use mannitol in the acute glaucoma, so acute angle closure glaucoma. Very rarely it doesn't work very well, and I think that's because the glaucoma is so severe, the angle is totally closed. I've found it to work mostly. I don't know, Virna, have you seen it work, situations where mannitol hasn't worked at all?
Yes, Prof. Actually, I have done. I mean, maybe a few weeks ago, when I want to do a phacoemulsification in patient with angle closure, when it is in the clinic, actually the IOP is well controlled. But when the patient was coming in the day of the operation, the IOP is high. So we do the mannitol infusion, and but after 1.5 hour infusion, actually the IOP is not even getting lower, but getting higher, Prof. So I suspect that probably, you know that because it is the hyperosmotic agent, sometimes it's it take the water to maybe to the ciliary body. So the ciliary body actually maybe udem as well. So the IOP not getting lower, but it is getting higher because it is closing the angle actually.
But I think that's in subjects who are waiting for cataract surgery, isn't it? Where you dilated the pupil, is that right?
No. I didn't dilate the pupil, Prof. So Actually, in my clinic, in my operating theater, we never dilate the patient with angle closer. So I usually do the dilating when it is in the in the bed, prof. So when it is under the microscope, then I will insert it the like mid dilating agent with the adrenaline, something like that. But prior it, I never give the midriaticum because I know sometimes in some patient we will have a severe acute glaucoma.
Right, right.
So that's why I never give the midriaticum prior the patient coming to the operating theater. But after the patient came to the operating theater, then I will give the adrenaline to the patient. So I didn't give it the midriaticum actually, but the IOP is high, so I do the mannitol infusion, but then the IOP is getting higher, not getting lower. I've faced a condition like this, maybe Dr. Desi as well, so that she asked.
Yeah, look, that's very unusual. Sounds very nasty, and I don't know why. Your explanation might be correct, Virna, but touch wood, I haven't seen it before. Yeah.
I don't know, maybe in our country, in my clinic as well, I have faced maybe not only one case, actually, Prof. Several cases, so not only one with mannitol and it's not getting lower. So then sometimes I just doing the trabeculectomy for the patient first, and then after the IOP control, then I will do the cataract extraction.
Right, right.
Sometimes like that. It depends on the condition actually. If it is too high, so I have to wait for several days.
Right, 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 right.
Even it could be 50 to 70, Prof. I have one patient with when she came actually 43, but after we we give the mannitol, actually the patient becomes 60. So it is not lower but higher, like that, Prof.
Yeah,
May I comment?
Yes, thank you. Please, Dr. Agus.
Yeah. Good night, Prof. Boyle. How are you?
very good, thank you.
Yeah. Okay. The same, I think, the same. My experience, like Dr. Virna. Yeah, I have maybe one or two patients with angle closure, acute angle closure, pupil dilated, and I will do PECO during operating theater, very high pressure. I give mannitol infusion, and with the hours, IOP more high. I feel operation and I doing the reschedule and doing the trabeculectomy. I have the trabeculectomy and then maybe next time when continue to PECO.
Right.
Very, very, very difficult one.
That sounds very difficult. Gee.
Yes, Prof. We have, yes, sometimes we face those cases.
Yeah.
I think we will proceed with the next question, Professor Morgan.
Yes,
Dr. Henry.
What kind of condition do we need to do vitrectomy? That's in severe ciliary block. So when the lens, this sometimes occurs after you've removed the lens and put in an intraocular lens. Occasionally you come to remove the viscoelastic and then the intraocular lens and iris just keeps coming up to the cornea. Even you'll stitch all the ports, inflate the eye, but it'll still keep coming up. And so then you actually need to do a pars plana vitrectomy. And you may actually, this is really a topic for another day, but you may end up having to do a peripheral iridectomy and cut through the zonules and anterior hyaloid as well. It's very rare. I've had one case in 20 years. It probably will happen to every glaucoma specialist if they practice for long enough. But the other thing you can do is simply put a 21 gauge needle through the pars plana, and if you don't have a vitrector, that is. In the old days when we did extracapsular cataract surgery and didn't have vitrectomy machines, we could do that. You'd stitch up and then put a needle in and find a syneretic pocket and let some fluid out. But the risk there is of vitreous coming out and getting traction and a detachment. It's safer to do a core vitrectomy, which you can do through the dilated pupil. You can see the vitrectomy. So just 2 ports, one infusion line and the vitrector, and then do a core vitrectomy, and then usually that will fix the problem. If you have to, then you can do a iridectomy and cut through with a blade or a needle through to the vitreous through the iridectomy.
Yes.
Yeah. That we describe it in actually that paper that you showed, that we wrote, describes that technique.
Thank you very much, Professor Morgan. And the last question is from Dr. Nadia, Prof.
Oh, here we go. Yes. So I found. Oh, yes.
Question, Prof. In optic nerve head.
She says that she found that optic nerve head drusen can mimic glaucoma, and we can ensure our diagnosis with OCT. If we don't have OCT, in case we were practicing in a rural area, how can we diagnose and treat those kinds of patients? Should we treat it as a glaucoma patient? Yes, so that's a good question. So look, OCT scanning has made the detection of disc drusen much easier. If you don't, that particular patient that I showed you, you could actually see the disc drusen, the little tiny sort of like little birefringent, almost like little pearly stones sitting close to the surface of the optic nerve head is what you typically see. And you can see them on autofluorescence. So if you can flick the slit lamp beam across to the green, you may see them on autofluorescence. You can pick some of them up on ultrasound. So if you have an ultrasound, but probably you won't have an ultrasound. Essentially, they occur in patients with a small optic disc typically, and often the nerve tissue, it looks like it's swollen and a bit clumpy without a blurred margin. So it's not papilledema, but you're seeing this sort of small, slightly swollen looking optic nerve. So in that situation, suspect optic disc drusen. I think in any situation like that, if the intraocular pressure is elevated, then you're safest to treat for glaucoma. That's probably the safest thing to do.
Is there any, like, do you have like any limit for the IOP, Prof? I mean, when will you start the treatment in those cases? Maybe Dr. Nadia wants to know about that.
Oh, I see, yes. So if there is any visual field defect or nerve fiber layer loss, then I would start treatment if the pressure is greater than 20 or maybe even 18. It depends upon how much visual field is lost.
Mm-hmm.
Give you an idea of the severity and the fragility of the remaining optic nerve.
Thank you very much, Professor Morgan. I guess we have quite a nice discussion about all of the topic for today, Professor Morgan. It's almost actually we planned to 7:30 in Indonesian time or 8:30 in the Perth time, right, Prof? But it's already like more 20 minutes more from our planning first. So I think we should end our session now. Is there any comment from Dr. Agus or Prof. Ike, or is there any? Prof. Ike?
Thank you. Thank you, Prof. Morgan, for your lecture. Yeah, how are you? Have you vaccine COVID?
No, thankfully we're all good here. I was going to ask, how are you all going? Are you okay?
Okay, very well.
Okay.
Tomorrow I will vaccine the second vaccine. Yeah,
A
vaccine
second
COVID. Yeah.
Right.
Sinovac.
Oh, good, good. I'm glad.
Thank you. Yeah.
Okay, so if there is no other comment from the participants, I will close this session. I will thank to Professor Morgan for the presentation and also Dr. Iwan for the case presentation. Thank you very much. Hopefully we all could learn about the acute angle closer glaucoma and also how to manage glaucoma. And I know cases with high myopia is difficult. Me too. I know that it is hard to to diagnose patient with high myopia, and also if we judging between whether it is glaucoma or not. So hopefully from this lecture from Professor Morgan, we could have more perspective about glaucoma, the causes, and also the appearance. And also hopefully we will learn more about the ocular examination, the clinical, like Professor Morgan have also, already told us, and also the OCT examination, and also the perimeter examination. Whole things in the glaucoma is actually related. So thank you very much, Professor Morgan. And we thank to also from the support from several industries. And also for the Faculty of Medicine, thank you very much. And also from Lion Institute, thank you very much. And I will end this session. And now, should we have a photo session with all the participants if they want to have? Dr. Mita?
Yes, Doc. If you want to, we can take photos.
Before we end our session, if everybody
Please
don't
open
mind,
the video.
yes, open the video and we could have a.
Okay, I will start to take the photo starting from the page 1. 1, 2, smile. Next page. 1, 2, 3. Next one. 1, 2, 3. Some just, okay. 1, 2, 3. Okay.
Sudah, Mita?
One more. Yeah, finish, Doc.
Okay. So please enjoy our next session. The next one will be in the second week as well. The joint lecture between us and also with the next speaker, right, Professor Morgan?
That's right, Virna. Yes, yes.
Please do come again, and when we could have a discussion more about glaucoma. Thank you very much. Thank you very much.
Thank you, Virna. Thank you very
you.
much. Thank you,
Bye.
everyone.
Hopefully you all will get
Yeah.
our permission.
Bye.
Bye.
Thank you, Prof.
See you again. Thank you.